All right, everybody, we're going to get started back here. Next section is return to play from obliques. We have PJ Mainville who's going to talk about rehab concepts. PJ's his 9th season as the head athletic trainer for the Chicago Cubs. He completed the previous 2 seasons as the Major League Assistant Athletic Trainer for the Arizona Diamondbacks. Spent 13 years in the minor leagues with the Diamondbacks and Baltimore Orioles organization. And he is ready to take over. Thanks a lot, PJ.
Thanks, guys. I appreciate you having me. First, I'd like to thank everybody on the call for the opportunity to speak today. I'll be speaking on the topic of rehabilitative concepts for oblique strains in Major League Baseball. Oblique strain injuries can be a rather debilitating injury within our industry due to the rotational nature of our sport. My plan today is to take you kind of on a journey at how I might approach managing an oblique strain with our players. As expected, the most common mechanism of injury for oblique strains are hitting and pitching, with pitchers requiring a mean of 5 days longer to recover from each injury than hitters. The lead side is injured in over 77% of cases, which takes longer to recover from the trailing side oblique injuries by approximately 5 days. The presentation of these types of injuries can vary from just general tightness, burning sensations, or even a stabbing sensation. In the more severe conditions, sudden pain and point tenderness can typically be located at the lower costal margin. The individual may have discomfort with rotation, coughing, and sneezing. An MRI is generally warranted to grade out severity and may provide a general timeline for return to play. I'm actually going to play a video here as an example of obviously it's how acute and I guess traumatic an oblique strain can be. Also, it's all of noting too that the backside is actually here the less common side, but as you can see, it can be pretty dramatic in some cases. First, we may want to appreciate that the oblique muscle is creating an increased tension of eccentric load at end range, specifically at maximal hip-shoulder separation. Secondly, the pitching motion inherently creates a layback of the trunk during the delivery or pitching motion. And lastly, the oblique muscles are being stressed in all 3 planes of motion, the sagittal, frontal, and transverse planes. All of these points are unique characteristics of the trunk in pitching relative to other sports, as a strategy or demand of the core is creating a lot of force to generate power by the means of hip-shoulder separation. An injury may occur when the capacity of the muscle at end range exceeds its ability to withstand the force or load demands. The muscle may also be influenced by poor mechanics or postural adaptations resulting from core decentration. Clearly, as discussed before and earlier today, the acute on chronic workloads and training are also influences. Fascial restrictions across joints can significantly influence movement quality, therefore creating a compensation in the kinetic chain. We can see with common patterning dysfunctions such as the upper cross and lower cross syndromes. We'll start first by looking at functional relationships of the core. The reason for looking at these relationships of poor functioning core may help us better understand the abnormal patterning concepts that might result. For one example, positioning of the glenohumeral joint is dictated by the orientation of the scapula. In this situation, the orientation of the scapula is dictated by the position of the thoracic rib cage. A decentrated core may also result in shoulder posture that is typically characterized by rounded shoulders, resulting in the tightness or shortening of the pec minor and other prime movers of the shoulder. Scapular decentration can also inhibit the ability for the scapula to create the fixation point for the shoulder. This lack of stability leads to forces traveling distally to the next stable joint, in this case would be the elbow. Patterning in the lower extremity may also result after injury. We commonly see a decrease in glute activation after ankle sprains. Weaknesses in the hip abductors and external rotators may aid in the abnormal tibial motion and patellofemoral pathology. In regards to low back pain and neuromuscular control, we see where hip range of motion asymmetry can be a contributing factor to SI joint pain. And lastly, motor control system fitness ultimately is critical to the spine stability, where the slow speed of the TVA contraction during arm movement is correlated with low back pain. These are just a few examples of how the core and its surrounding influences can affect the regional relationships of the body, and specifically in this case, oblique strains. We'll briefly take a look at the musculature influencing oblique strains. The muscles highlighted in green will represent the abdominal wall and the function to create intra-abdominal pressure, those being the internal and external obliques, transverse abdominis, and the diaphragm and pelvic floor. The glutes will become an area of focus to create stability of the pelvis by mitigating anterior pelvic tilt. While the serratus anterior is important to create orientation of the scapula and a thoracic rib cage to help create a stable fixation point for the shoulder. For purposes of this talk, we will be looking at 4 concepts. They are length tension relationships, diaphragm function, intra-abdominal pressure, mobility restrictions, abdominal activation, and then Nate Shaw will follow me up later on with skill adaptation and blending of exercises. So first, we'll start with length tension relationships. Length tension relationships inherently occur all over the body amongst agonist and antagonist muscle groups, but adaptively, these muscle groups are generally classified as either short, overactive, or long and inhibited. These disproportionate relationship can influence the joint position and ultimately joint centration. In this example, we kind of use a tent pole. If one aspect of the tent pole line is pulling too hard, it can change the position of the pole itself. 2 classifications are described by Yonda, and they are the upper and low cross syndromes. Our approach would be if we can change or decrease tightness in an antagonist, strength will generally increase in the agonist muscle group. We know that specific muscles are prone to tightness and weakness, and these concepts describe Sheraton's law of reciprocal inhibition. This sagittal view demonstrates the adaptive nature of upper and lower cross syndromes. The elevated rib cage and anteriorly pelvic positioned pelvis are common stereotypes for these types of patterning concerns. In the picture on the far right, you'll see where the shortness of the quadriceps and positional length of the hamstring are an example of this length tension relationship described. Also seen are the open scissors concept that are consistent with an elevated rib cage and anteriorly pelvic position. Rounded shoulders are due to the overdominance of the pec and lat teres. One means of assessment for is the overhead flexion test. The first observation is the elevated rib cage and poor core control. The second is the shortness noted of the pec minor and the latissimus, pec major and minor, and lat teres muscles. The goal would be to flex the humerus to 180 degrees of flexion without his low back going into extension or upward rotation of the rib cage. This is an example of a dynamic rib positioning test. On the left, you'll see where the rib cage elevates. Some of the restrictions, again, would be the pec and the lat teres. With some cueing and some proper training, the rib cage stays down, still exhibiting some minor length deficits in the lat and teres and pec, but generally better. So a summary of the lower extremity, these elevated rib cage and anteriorly positioned pelvis are the catalyst for the disproportionate length tension relationships of the hamstring and quadriceps. Essentially, the poor core function or stabilization leads to poor pelvic positioning. The increased length tension relationships are then seen in the hamstrings and quadriceps, and ultimately this positional length of the hamstring leads to injury. This feeling of tight hamstring may be the result of the positional length we just described. Also, the inequality of the agonist-antagonist relationships that we see. There are synergist influences, and we do see limitations in dorsiflexion, great toe extension that may limit the glute's ability to activate appropriately. The use of the tongs have been used in measuring the relative tilt of the pelvis. This can be used as a guide to either set measures of acceptable norms or red flag players that could benefit from corrective programs or intervention. Additional objective measures of hip, IR, and ER, typically asymmetries are common. but clinically we're looking to see if we can't find an acceptable total arc range of motion of somewhere around 70 degrees. This may give us some insight to understanding the pelvic orientation. Manual therapy can significantly improve the function by changing the fascial restrictions along both the anterior oblique and posterior oblique slings of the body. This allows the ability to facilitate antagonist groups in hopes of creating improved joint function. The patient may also benefit implementing the manual therapy prior to mobility work. One thing noted in a recent episode of an oblique strain that we had, there was actually a compensatory tightness at the QL. That was something that needed to be addressed manually. Looking to correct some of these length tension relationships, there are numerous ways and a comprehensive means of trying to do that. Actively stretching the front side, especially the upper 1/3 of the quadricep. Actively rotate hips posteriorly. Looking at repositioning of hips. Manual therapy, obviously, to address some of the fascial restrictions. One means of doing that would be fascial manipulation and then assisted tools. And then we'll get a little bit more into the posterior lateral pressure and the diaphragm coming up, as well as the stability system. Secondly, the diaphragm function into intra-abdominal pressure. The ideal norm would be to have ribs stacked symmetrically over a pelvis. On the right, the position of the rib cage show an elevated rib cage, which is poor for creating the stabilization of the core. The ribs themselves are reciprocal in nature. They too work in all three planes of motion. One observation is that the left rib cage in this scenario can be characteristically flared. In this case, we'd need to appreciate how the abdominal obliques attach and make an emphasis on the left-sided abdominal wall activation. The left side of the diaphragm is differently domed. The right side is shorter, tighter, and more compact. This can be one potential reason for why we see some of the left flaring, as we saw on the previous slide. The ideal norm on the left illustrates the proper function of the diaphragm by the rib cage expanding laterally and the pelvis remaining neutral. This is only possible by proper doming of the diaphragm to create the ideal intra-abdominal pressure or stability of the core. The one on the right is going to show an upward elevation of the rib cage and the pelvis that tips forward anteriorly. Again, going back to stacking, the fact that the rib cage over a pelvis will help maximize the ability of the diaphragm and pelvic floor to create the intra-abdominal pressure. The means by which intra-abdominal pressure is created is essentially creating a pressure within a cylinder. The abdominal wall is pressurized by both the respiratory diaphragm and pelvic floor, resulting in a fixation point for the upper and lower extremities. One of the testing that we'll do with this is a seated diaphragm test, the one on the left. The one we're trying to look at the ability for the expansion of the lateral abdominal wall and his ability to create that lateral pressure. On the right, we're looking more at the seated pressure test, their ability to create pressure in the forward toward trying to create the pressure coming towards you so that they can see whether or not they can create that pressure downward and not use a compensatory pattern of the upper thoracic. Next, looking at mobility restrictions, hips and thoracic spine. Sideline twist with hip shift, basically an open book. I think what's important with this particular exercise, obviously well known to most people, this exercise can also be used as a test to gauge asymmetries of the thoracic spine. Obviously making sure that they don't cheat and try to keep the knees parallel to each other. This is kind of a modification to the open book that we've been using. It's been really effective in a lot of our guys as to where they do have limitations. It's simply a muscle energy technique. In doing so, they do the same open book maneuver. They'll hold against my arm for roughly 10 seconds. They'll take a deep breath, exhale, and I actually take the space that he gives me, and then we repeat that in hopes of gaining full range of motion. It's actually been a keystone exercise for us in terms of normalizing thoracic range of motion. Next to the all fours walkthroughs, basically changing it up where the stabilization point becomes the upper extremity. Really trying to, again, get some motion where they're maintaining the thoracic, the core stability, but now trying to integrate more thoracic rotation. That next, the abdominal activation, getting into the motor control exercises to advance load. Reintegration of motor control exercises to advanced load starts by introducing a proper stabilization and breathing function. The goal is to create 360 degrees of intra-abdominal pressure to create stabilization for the spine. With that being said, in this picture, the video on the far right, what we're trying to do is create a pressure with inhalation, increase the pressure with inhale, maintain the pressure with exhale, and then maintaining a pressure with alternating toe tap would be something that would be a bit more advanced going into the exercise progression. This exercise is new for us in the last couple of years. We've spent so much time on trying to reposition a thoracic rib cage. In this scenario, we're actually isolating the left hip and distracting it. Where our point or our objective here is to try to get them to facilitate left ab wall activation. As you can see here, I'm distracting his leg distally. You can see he's kind of got that open position. We're going to ask him to bring a rib cage to a pelvis actively. And I'll say, by having done this, we really found some disparity between the left and right abdominal walls. And we've been using this as a kind of re-education tool to find that ab wall that they may be deficient in. Next, progression-wise, pretty standard dead bug activation. Again, trying to keep the intra-abdominal pressure stabilization. Obviously, we can advance this by doing alternating to the ground. We could add weight, we could add resistance with TheraBands. Then moving to an unstable surface and increasing the difficulty from there. We'll use kind of what we call a DNS roll. This half roll on the left, essentially coming up. The importance of this is now we're facilitating a left glute, and also having to stabilize a scapula on a rib cage while maintaining the the abdominal pressure and stability. The DNS roll with the resistance, this is another staple we've been using as of late, putting them in the same position and counting them down 5 seconds where they've got to maintain that eccentric control. And we'll do that both left and right. Next, in the anterior oblique sling 4 corners with a physio ball. In this position here, we're basically activating the anterior oblique sling and alternating it, typically hold for 3 to 5 seconds, and try to build them up to sets of 8 or 10 reps. Sorry, yeah, probably 3 sets. Next, 6-month position ball walks, pretty difficult exercise. Definitely encourage you to take your shoes off on this one. Pretty challenging through the positioning. Half kneel with scapular depression. Now we're starting to lock in that scapula, keep a stable core. We're activating a glute posteriorly and then lengthening the front side, upper 1/3 quadricep. May actually add in some left adduction as well of the leg. Here into the next, we're actually creating that hip-shouldered separation, same concept through the movement. Half kneel with punch. Now trying to facilitate that same motion of hip, shoulder hip separation, and now trying to create serratus activation at the end. And lastly, going into a half kneel chop. In summary, as we start looking at seeing an overall increase in demand placed on the oblique musculature due to poor diaphragm function, can cause a decentration of the core and lack of intra-abdominal pressure, compromising a fixation point for the extremities. The lack of stabilization adaptively results in the elevation of the thoracic rib cage and promotes an anterior pelvic tilt. Areas such as the hips and thoracic rib cage take on more of a stability role, limiting the range of motion during rotation. Length tension relationships of muscles can then alter joint position and place a higher demand of tissue higher demand on the tissues already positionally long. In this situation would be the obliques. A reintegration of proper core function and intra-abdominal pressure set the table for facilitating proper length tension relationships. Reinforcement of these patterns must have a comprehensive corrective program. Final thoughts. Obviously for us, the collaboration of your high performance team is essential. Really want to thank the group that I work with. Obviously our medical staff, our athletic trainers, physical therapists, strength conditioning professionals, nutrition, mental skills. Truly is a team that we work with. And lastly, while it's all important putting these programs together, it is important to recognize that each individual player moves differently. Therefore, programming must be individualized. Thank you.
Thank you, PJ. The next talk is about training concepts in relation to the oblique muscles. And this is Nate Shaw. He's the Major League Strength and Conditioning Coordinator for the Arizona Diamondbacks. 17 seasons with them. He got his ATC training through the University of Florida and was also a PT Tech. And he was involved with the Blue Jays through an internship and with the Tampa Bay Rays. Thanks, Nate.
Well, thank you. I think everyone, like everyone else on this panel, I really appreciate the opportunity to be here. It's always a really unique opportunity to share with everybody the fortunate things I've been able to go through. Can you guys see the screen okay? Quick little microphone check, audio check, everything's good.
Okay, Nate.
All right, buddy, here we go. Let's see, slideshow is started. There we go. All right, guys. So first, I always like to start off all of my presentations, with a little bit of gratitude and thanks to the people that I work with. They give me a lot of the opportunities. Any of the presentations that I do, any of the opportunities that I have, I wouldn't be as sharp, as experienced, or as as polished, if that's a word you can use to describe me, without the help of my teammates. I'm really delighted to be a part of our sports medicine performance team. We have a nice little vision, mission, and values moniker that we just always go back to, and we're committed to enhancing human performance. And we're trying to be the best sports medicine performance team on the planet. And at first take, that maybe sounds a little bit cocky or whatever, but I think what we're trying to do is we're trying to climb an endless mountain. And I know everybody does that. Everyone has their own version of that, but this is kind of where we come from. And this is what we as a group try to do on a daily basis. So this presentation is all the good stuff in this presentation will be from my teammates, and all the mistakes I make along the way, those are mine. So I think anytime there's a rehab situation, man, you can look at it in a bunch of different ways. Sometimes things happen for a reason. I always look at it as an opportunity. This is an opportunity to teach breathing patterns, train for position, length, tension relationships. Like, I think that the thing that we really like to do in all this is in general have our philosophy, and our philosophy is based on position and posture. And I think those things are really important. And as we go, we're gonna talk about local strength. We're gonna talk about movement and mechanics efficiencies and vectors and teaching work habits. But when someone gets injured, it's a time for you can get to spend a lot of time with them. So it's an opportunity to really kind of like Mike Reynolds said earlier, it's kind of just like a chance to optimize. And I think that's the way we tend to look at it. So I learned some cool stuff very early on from Kevin Barr. He was the Major League Strength conditioning coach when I was in the minor leagues at Tampa. And, it's really all about choices and making good choices. You may see the Injury Hall of Shame is just something that we have as a reminder to just, hey, look, man, things are going to escalate. Things are always going to have bigger consequences than you think. And I blocked out some of the names, but you may, if those of you that know, there may be a PJ Mainville sighting on this Injury Hall of Shame, making poor choices around basketball and plantar fasciitis. I don't know. It may or may not be true. I wouldn't want to throw anybody under the bus or anything like that. I think when we start talking about choices, though, real simply, relationships in the weight room are really important, and making choices to build relationships is a very fine art. And, I think at times you're going to have to do whatever the athlete wants to do. And they may believe that they are in the major leagues because of their program, and you may actually believe that they're in the major leagues in spite of their program. So a couple things that I don't like to make the meat and potatoes of anybody's program with, you know, the overhead stuff, bench press, dips, anything behind the neck. I mean, we've looked at labrums and we've talked about anatomy, and this isn't the time or the place for that. This is a practical applied, hey, do this, don't do this. This is how we think the presentation. So, you know, gun show, biceps, hammer curls, standing oblique crunches is a definite no-no for me. I mean, there's no better way to smash facets against each other than to do a standing oblique crunch with a dumbbell in your hand. I think the Olympic lifting, you know, it's super coaching intensive. It's a little bit dangerous if you're not used to it and you haven't built up a tolerance for it, you know, in the acute chronic world. So, you know, and obviously knee extension machines, and for me, heavy squats are they're just the risk reward benefit just doesn't play. And, you know, I think in training, guys, everybody has an opinion about what should be done in the weight room. There, you know, a lot of people have opinions, and I just always want to start off and just go back to the fact that, hey, you know what? Baseball's different. You look at these bodies and you got, you know, this guy won the Cy Young 200 innings 5 times. This guy 200 innings plus eight times. This guy was in the MLB for 14 seasons. And then, you know, when we switch over to the position players, if we rank these bodies, right, the number one body, like who looks like the best weightlifter? It's the guy all the way on the right, Roy Jones Jr. Okay. The next guy I would probably put this outfielder. I would say then for me, I would take this outfielder, then this one and this one. And it's funny. That's just a you know, eyeball test. And you see what the numbers represent? The numbers represent kind of the exact opposite. The guy with the best body hit the least amount of home runs in the big leagues. Right. And these are players. These were good players. These are players that played for a while. These are players that made a lot of money. So, you know, thoughts around what the weight room should be and what the weight room shouldn't be need to be tempered with the concept that, hey, baseball is a little bit different, and it always is. You know, I think it's important to stress that you know, durability is something that we really focus on. You know, we don't want to break them in the weight room. It's important to know this isn't a cross-country team. It's not a weightlifting meet. We just try to find a better position, try to keep them so that they avoid training gaps, and we want them to be stronger, no doubt, but we want them to play longer too. So it's definitely a nice soup that, you know, is tough to manage ingredients sometimes. So it's certainly an art. I think in general, we like posture. It's kind of a catch-all term for us. It means length, tension, it means position, but the reality of it is it's the beginning and end of all movement. And I think it's really important to look at your program and look at your athlete like that. PJ did a great job of putting together the concepts of the position and length tension relationship. So I'm not going to belabor that point, but I do really like the graphs. I like looking at it. And I think if you can think from a position of shapes and position of the bones and how they all function together, I think you're kind of on the right track. At least that's the way what we do and what I found to be successful. So, you know, the things that we're going to focus on breathing, functional and indicated exercises. We want to be mobile. We love mobility. We love flexibility. We like yoga if it's the right time. We like all those things. Just we want it to be right for the right guy. Mobile and strong is what we need. And we do a lot of strength stuff. We do a lot of single leg. We do probably less double leg strength, less bilateral training, possibly than most teams. But really what we're trying to do is just gain position, right? Get them in a good place where they're going to be efficient, and then help them get strong, then help them generate force. And, you know, some of that starts obviously isometrically, and then we go to concentric and eccentric, and then we start doing it quickly. And we're trying to just get these players ready to play. And, you know, no one wants to see an injury. You know, that's not a grimace because he threw a ball. That's a grimace because he just pulled his oblique. There's obviously a ton of rehab checkpoints. And when you're working in the weight room, you know, I'm super fortunate. We have a great relationship with the training staff. Our rooms are right beside each other. There's either a window, a wall with glass, or just some glass or a door. Like we are so connected. It's perfect. So yes, there's checkpoints, right? There's continuums that you have to worry about. Pain, right? Is it constant with no movement in the very beginning all the way till the end, where it's non-existent through all ranges of motions and movements? And then of course, all the criteria that you're going to have to progress through, right? Walking, standing, hitting, throwing, running, base running, if they're a position player, PFPs, if they're pitchers, and then work capacity and conditioning. So these are all things that you have to manage and think about. For me, the important part in all this is look, stay within the guidelines, and then let's just do a test retest. You know, let's make sure we're on the right thing. Let's be critical thinkers, and let's progress when we can and regress when we have to. Now, what we're going for is pain-free, and then we're going to go breathing, rib mobility, glute function, hamstrings, internal rotation, just getting the body to be able to move. And all the while, we're going to really try and reestablish good, strong oblique function, and that means we're going to have the serratus in there, and we're going to get everybody working together, and that's kind of the plan. So this for me is super important. We have to teach these players how to breathe. You know, have them, hey, take a nice deep breath for us, and you'll see, you know, this young specimen right here has a big, huge inhale on purpose. And then you see his ribs move up and then down. And ultimately, that's where we start. So then what we want to try and do is we want to try and cue them. Hey, look, can you breathe in, use your diaphragm good? We help hold their ribs down so that they can hopefully be able to create some pressure and actually breathe in, inhale, and push my fingers out to the side, kind of alluding to that 360-degree concept that PJ talked about. And then when we can get them to breathe that way, then what we want them to do is we want them to be able to hold that pressure, right? We want to be able to have the DNS holding pressure that we all know is so important. And then as we go, then what we do is we want it to be all the way around and them to be able to hold that position. And then once they achieve that, then we won't do that as active rest anymore. What we'll do is we'll start progressing from there. But that's our baseline deal. And, you know, we do simple things like talk about exhales and talk about breathing, and instead of counting reps, like simple things like that's what we're going to do. We're going to really focus on position and breathing right away, as soon as we can. You know, I really like the pictures and the graphs. I'm a simple mind. I'm a visual person. And so to me, these are some exercises that you can do. You know, PJ mentioned some of the DNS crawls and tilts and some of the positions, but functionally, like this is what we're trying to do right here. We're trying to lengthen the lumbar paraspinals and, you know, posterior pelvic tilt and get the obliques going. So what better place to do this? They call this the 6-month position because the athlete can touch, or excuse me, the baby can touch not his hips, not his knees, but can grab his feet. So nice little landmark there, but we can still do that when we're adults. And some adults actually have more problems doing it than the kids do. So here's another position one. It's an early position. And really what we're trying to do is trying to get some thoracic extension here. We're trying to use obliques, trying to use hamstrings. It's the same concept again and again and again. And that's what we really try to hammer home. So now we'll get into a little bit less elementary, but still fundamental concept. And what we're looking at here on the left is, you know, we're looking at hamstrings. We're going to squeeze this ball to get the adductors going. And what we're really trying to do is just change the orientation of the hip nominants as they relate to the leg musculature. So this is a simple bilateral one. This exercise here is now a little bit more integrated, right? It's the left hamstring. We're using the left serratus. We're using the right obliques. We're using the left glute. And, you know, you start to see some common themes here. And what we're trying to do is get these muscles to work in sequence. This is some nice subacute stuff. I think PJ did a good job of covering this. So in the interest of time, I'm gonna whiz through that. This is another exercise that we do in the weight room. You know, like PJ mentioned, there's a lot of interaction between the weight room and the training room. And so there's a lot of blend in a talk like this. And it's a wonderful topic that we could talk forever on, and we have 20 minutes. So, you know, I'm trying to cut out some of the gray area. This is another hip position hamstring exercise where we're putting the lat stretch and trying to lengthen and posterior pelvic tilt, lengthen the low back. So simple stuff. Again, what we're doing is we're just trying to reiterate these positions, right? Rib position, pelvis position. Now we're throwing in there in a position where we're looking at thoracic mobility and hip mobility. So if you look carefully, we're using the bottom oblique. So on this superstar athlete here, we're using his left oblique to stretch his right posterior flank, if you will. Right? He's using his serratus, he's using his hamstrings, he's using his obliques, and we're getting some good range of motion and we're getting some good facilitation. So I'm a big fan of that. We do regular stuff also. We do rotation, we do lunges, we do anything. Mostly we try to do movements and functional activities. And so in this picture, you can see what we're trying to do here is we're trying to focus on how good he uses the inside edge of his foot In the picture on the left, you can see his foot kind of pops up a little bit, and that's just not an efficient position. His center of gravity has moved outside of his foot, and he no longer has a punctum fixum or a stable base or any of those things. So what we're trying to do is we're trying to create a little bit of internal rotation up here in his hip joint and create some strength. So if we can use his peroneals here, his adductors here, we're going to use his glute medius more, and that'll help us turn his other oblique on. So what we're really doing is trying to look at how well he can get his body to move. And as we get better at that, what we try to do is then we try to put load. Sometimes we use load to teach, right? This is just a nice hip strap, and we're just trying to get this player to understand how to move and get things going in a good sequence with a little bit of resistance. So let me see. Simple stuff. I mean, everybody does all these. Everybody's doing, but this is an intermediate, kind of more meat and potatoes, probably less training room, more weight room. So gonna play this video here. I know I'm running. I got about a 5-minute window left here, so I'm gonna play it, and I might skip forward a little bit. This is an end range isometric where he's trying to just it's a pails rails trying to get to the end range. I think the stick makes it really easy to use and quantify. So as we go, it's a way for the athlete to see progress. So I'm going to skip forward a little bit. This is just a simple pull-off press, right? Just walking out to the side, just looking at always changing the vectors of all of the exercises so we can challenge the obliques in different ways. And this is kind of a take on PJ's the DNS position that we were talking about earlier. Simple dead bug with a little bit of a different vector. This is an excellent exercise. I don't really know what we call it. I call it the dots. I try to simplify things so the players can understand them. But really what we're doing is just a modified plank with hip flexion. And what we're really doing is really just putting the oblique system in a really shortened position and helping it work. And then as you get better at the isometric part of it, then you can add in the separation. We call this the dots. It's a pretty simple exercise. Let's see, get back to here as we continue. We'll move into some side plank variations. You start at the knee first, then you move out to the ankle. The bear is awesome. You can go sideways with it. And all we're doing is we're really trying to cue up good position here. We've worked on exhaling, we've worked on pressurization, and now we're trying to throw movement in there. Forward, backward, sideways. This is another variation, kind of the walk around that we showed you. Trying to get high using the bottom oblique and just keeping these guys in the move. Farmer carries are awesome. We do a ton of those. You can do a waiter's carry. You can go through and do the chop series is fantastic. Ups, downs. We're really just trying to do is just trying to put the oblique in different positions and build strength. We have to build facilitation and function first, then strength, then we're looking to layer on work capacity. So we really like the aqua balls. We'll talk about that a little bit more in the running stuff, in the running phase. It's important to note that you have to use all three phases: the isometric, the concentric, and the eccentric. And I think if you think and try not to miss any of those different phases, then you're going to really prepare the athlete. We do basic strength stuff too. Whenever we do some heavy squats, we usually try to do something right afterwards where we turn the obliques on and try to turn off the lumbar paraspinals. This video here is more as we get closer to getting back to the game. You'll see forces are going to be higher, speeds are going to be higher. We love the landmine. We love switching legs. We love lighter things, moving them faster. There's a million things that you can do. These Bosch balls are fantastic. They're just a CNS, you can either crush the CNS with it, or you can just turn the CNS on. It all depends on what exactly your goal is. And I think as we go, you work one side, then you go to continuous, and there's tons of different med ball variations that we've all seen. So, I want to make sure that whatever you're doing, there's a progression to and a regression to, and there's a method behind it. Much like what Reinhold was talking about earlier with just a progression, just something that's smart, and it can be common sense, and just try to have a plan for what you're doing and look at what you're trying to get and constantly evaluate that. So when we're warming guys up, we'll do some of the simple aqua back stuff, front and back, side to side. Then, this is a nugget that I really like to share with everybody. We did some anterior posterior pelvic rotation measurements. And, these low dribbles, these are the best things since sliced bread. Like when you have a hamstring or an oblique or anything, you can go slow with them and you can do a low dribble. And then as they get better, you can progress to a medium dribble. And the angles are smaller and the forces are less, but you can increase this all the way. So the reason I like this exercise so much is because it actually changes the pelvic tilt while you do it. So it's an active, a sport-specific activity that's fantastic, you know, and it's we do it as a warm-up, we do it as a progression, we do it all the time. I think my guys love it, or maybe they hate it, I'm not sure. A couple of really good tools out there for obliques. You know, you get these guys running, get them in good shape, get them in condition. I look at the Alter G is just absolutely fantastic. You know, we've put a ton of players in there over the years, and, you know, they just, it's just a way to bridge the gap faster. It's a fantastic piece of machinery. We talked about optimization. You know, this is a great time to work on knee drive. If they don't have good knee drive, arm swing, and you know, you can work on all these things at sub-max levels. We do a lot through just the speed drills. We've had a chance to work with Altus a ton and just have had the opportunity to learn a ton. So for me, it's all about, you know, lower speed drills that can help reestablish work capacity and efficiency in these athletes. And, you know, hey, listen, let's not look past conditioning. A good VO2 max is good for the body and for the soul. So, you know, I think that's the gist of what I've got for you guys. I know it's a broad topic, and gosh, there's so much gray area in there, but just want to say thank you to everybody for letting me be involved in this. And, you know, this is a picture of all of our some of our sports medicine team guys just being team guys. And, you know, we have a great environment and we love working together. And, you know, they're the reason that I get to be up here and talk to you guys. And, you know, the credit goes to other people. I'm sure there's a ton of questions. I don't want to take up too much time. Thanks for the opportunity.
Nate, thanks a lot. I'm going to pull in our panelists to help us out here. One of them is Brett Walker. He's the assistant athletic trainer for the White Sox. He's spent 7 years with the White Sox, has a master's degree in physical therapy and a bachelor's degree in athletic training, both from the University of Mary. The other one is James Crook. He is the head athletic trainer for the Chicago White Sox, has a master's degree in athletic training, and is a certified strength and conditioning specialist. Thanks for joining us, guys.
Thanks for having us.
The first question here is for PJ. What is the app you used in the photo for measuring seated hip internal and external rotation?
Actually, it was just our iPhone. So simply put, I mean, whatever works for you at that point. We've done it obviously with the normal goniometers, but whatever works with you. Generally, it's just an iPhone.
What do you feel is better, PJ, the iPhone or the using the goniometer?
I think overall, as long as you're consistent in your measures, you can delineate out from whether there's an abnormality or change in the range of motion. I think that's most successful in our experience.
All right, for the group, what would be your ideal progression? Breathing, DNS, functional patterns, and specific drills?
I think Nate and PJ did a pretty darn good job working with starting with isometrics, their breathing drills. You know, I don't know if that's everyone that does the breathing drills, but I think that there's an important point there that they were making. I really think that Nate did a really good job on the progression of exercises afterward. You know, for us, we really look at rotational versus side bending, combined motions. Of course, starting isometric, concentric, eccentric. And then I think just working into adductors, glutes, low back, especially, I think PJ mentioned that. Talking about the QL, I think that's a very impactful thing for these obliques. You know, from there, I think James, like when we work, as we get started going through those progressions, I get a lot of the beginning stages and kind of hand off to James as we get into more baseball activities. So I'll just toss it over to him.
Yeah, I mean, PJ and Nate did a great job kind of laying out the base form. And then once you kind of progress past those exercises, and obviously you're going to have things that continue through the progressions, but also once you get into the baseball activities, PJ had mentioned, you have to keep in mind that all these programs need to be individualized because each guy's a little bit different. What position are they playing? Are they a pitcher? Are they a position player? Are they a catcher? Are they going to have to throw off one knee or field a ball and throw, or get a ball in the hole and make that throw, and almost kind of get to the point where you're recreating what the injury was. Was it a swing and miss? Obviously we don't want anyone swinging and missing, but it happens. So these are all things that we have to build into the program. So not only have they already checked that box during the rehab, so psychologically they're also okay with, okay, I've done this, I can do it. So they're not doing it when they're back on the field, they're doing it beforehand. So they have the confidence to do it while they're on the field.
Touching on your swing and miss, does that change your guys' thought process as you're progressing the guys, whether it was a swing and miss or whether it was like a swing and stop?
I think both are two very important things because a lot of times you see it sometimes on a swing and miss, but also on that check swing. For us, a lot of times these are just kind of boxes to check off as you want to kind of cover all areas and make sure that there's nothing you're leaving out, that when they get to that game and when they're full go, that they're not missing those pieces.
I think that one of the things that our staff has worked on over the last year, especially with James and our minor league PT Brooks and Ben Hansen, our biomechanist, has really pushed us to look at some of the data a little bit more. As far as I know, James this year was using our hit tracks in the cage to almost document where they were prior to injury, and then as they started returning, hey, what percent is this guy at? I know we had a shoulder injury at one point this year, hitter who, when we started him in the cage, his exit velo was significantly lower than where he normally is. And then we get another injury who comes in and his looks really good in comparison to that guy, but is significantly lower than his norms. So I think that just having some of those more of those data sets and the team around you to be able to help you step back and take a look at those is really important.
This one's probably more for Nate and PJ here. How far have you guys looked into postural assessment with your players? Have you found jaw face symmetry to dictate your corrective interventions at all?
Can't say that's one that we've taken into consideration as of yet. To expand a little bit on that, I mean, we're always looking for those types of changes through the body, those asymmetries. Ultimately, I think a lot of that's based on your screen and what you might be able to take from that. And I guess that's one thing I wanted to bring up in the discussion component of this is, when these injuries occur, everyone on this call, for the most part, has that feeling, that sinking feeling after an injury occurs. And I think there's a lot of relatability there in terms of the emotion that goes with that. And then you go back and assess the individual and you realize that a measurement may not be within the norm that you were expecting to see based on where he was prior in the season. And adaptively, he's changed. Now, that happens throughout a season. We all understand that. But when it becomes a glaring deficit, I think that's one of the things where we wanted to, I don't know, there's a part of, I don't want to call it a guilt, but there's a part of it where you wish you had maybe had an opportunity to assess that prior before the injury. So it's all retrospective, but I think it's one of those things that we all go through in terms of a why.
I would also add this, in our population, I think there are things that stick out that are the normal things, normal items. We do we used to do a thorough postural exam for a long time, and it was fruitful. to a point. And then we realized that, you know what, our basic program kind of takes care of a lot of those postural measurements. And, you know, there are people that have vision issues, or they have jaw alignment issues, or, you know, and that's you know, the PRI folks are fantastic at really climbing down that rabbit hole and ultimately figuring out what the little trinket is, the one micro piece that actually makes the difference in that guy. And I would have to say, it's true that is that obscure, that makes a huge difference. It's not that it can't, but in general, in our population and the masses, you know, this is a pretty robust, durable part of the gene pool that, you know, is pretty skillful and pretty amazing.
Do you guys change any of your thought processes depending on where the injury occurred, or to what structure of the area was injured, or does it really matter? You know, and looking at it from talking about abdominal stuff, you know, maybe even touching on, you know, sports hernia type stuff also.
I guess for me, I mean, I would go as far as to say, I'm always constantly looking for the why within the kinetic chain. And I don't know that we always find it, but definitely gives you a starting point as to where we might want to, you know, fixate in on an area that may be limited or not active. I think there's a lot of intuitiveness to that as well. I mean, I think as you start looking up and down, I mean, a lot of cases, just in one example, I start with the ankle. I look at how the ankle actually impacts, you know, the kinetic chain as a whole. And, you know, it's one of our first questions in our assessments is, have you ever had an ankle sprain? Because that does have a carryover effect even to the contralateral side. So I think there's a lot of intuitiveness when you start going through the assessment process. But ultimately, I feel like most of my thought would start with an oblique strain as being more the victim and trying to figure out where in the chain did it fail.
You guys feel like oblique injuries have increased, or is there different reasons that we feel like we see it more?
Jeff, I think that the research, at least the last article that I read, actually said that in the major leagues, it's actually decreasing, but in the minor leagues, it's going up. So I don't know what that has to do with, but that's just the latest research that I'd read.
How much of the breathing or positioning exercise do you put in a program from a workload standpoint? And how do you guys tie it into your programming?
I use it, I would say, in an oblique situation, or somebody that's injured, or somebody that hasn't been focusing on it. Like it's the first thing they do. It's something that everybody does in a warm up. We call it the Starbucks 20. Guys will come in and they'll be doing, you know, whatever, rolling on the foam roller, and 6 feet apart, of course, in 2020. So with masks on, and you know, there's something else to manage on top of that. But I think we throw the breathing in there, and, you know, there's a bunch of different ways to teach it. And I think once they have the skill and they have the ability to function, then it doesn't necessarily have to be the focus of the program. It's like it's a cornerstone, it's a fundament, it's something that's super important. But once they have it, then they can just use it. You know, it's only a huge deal if they don't have it. So for me, as far as programming goes, I think that's kind of along the lines of the individual programming, and depending on what their deficits are. If someone has a really big, difficult time trying to master it, and they have a really stiff rib cage, then, you know, those players tend to require more reps to get it going, you know. And you can use a lot of the DNS principles. You know, the more laced in your program, the more DNS, the more PRI, the more corrective based your programs are, the less time it takes. It's like skill acquisition, right? If you can get extra reps in the weight room, then you're going to get the skill faster. So, you know, that's a hard question to actually answer with a quantified number, because it's an individual basis, but it's a baseline that they need to have, and it needs to be strong, and it needs to have work capacity. And then we can go from there. Hope that answers your question.
When do you guys feel comfortable with initiating your hitting or throwing progression after injuries? Like, what are your main points to be able to progress to that?
I think for me, obviously, the obvious of ensuring that they have full range of motion, pain-free. I guess for me, the thing Nate just hit on a little bit in regards to the ability to manage their core stability, ensuring the fact that they have proper and full range of motion through their thoracic rib cage, hip total arcs are within reason. I think a lot of things that we would deem potential risk factors, in the kinetic chain, I think have to normalize for me within a relative degree. There's always a time against the clock in this industry, and I think there's a lot of things that can be meshed or brought along together. You may be able to start a hitting progression off the tee and then bring together some more of the advanced strengthening as you go forward. But you have to be very careful with that. I think getting a good strength basis underneath you. I like a lot of the plyometrics in the weight room with the med ball. A lot of the stuff that Nate was showing in the latter half of his presentation. I like those as checkoffs just to make sure that we can't recreate a pain pattern.
Yeah, I would agree. A lot of this stuff is going to be, returning their baselines of their range of motion and their strength, and then continuing with some of those velocity-based training type med ball stuff, as well as plyometrics before we get going from a throwing and hitting standpoint.
The one big thing that we try to think about is also the number of swings. We've talked a lot about workload. I think that group of guys did a great job that talked about workload. But as we get back, one missed day is a big deal in the number of swings a guy takes. And so now we're multiplying this. I think they said the average loss of time is roughly 22 days. I think, I don't know if PJ, if you said that or that was something that I read, but I do think that just as we get back into hitting and once again starting to talk about programming those swings is a very important step in what we do.
With a long layoff with injury, how many at bats or how long of a rehab assignment do you guys feel is necessary?
Yeah, there's a lot of factors that go into that question, obviously. I think we've always tried to standardize at minimum 20 to 25 ABs at a rehab progression or rehab assignment, but that doesn't always happen. Depending on the player, the nature of their position, their role in the team, that can be severely expedited. I think ultimately we try to shoot for at least the 20 to 25. There's got to be a level of comfort. There's one thing I learned years ago when I was in Arizona. We had a player that had a wrist injury, and I can remember he came back too soon, and this guy never became the same hitter that he was the rest of the year. And I think it was just he never felt comfortable. So there is that aspect emotionally where they've got to have that internal confidence, and I don't think that can be ignored.
I would agree with that. I mean, there's even certain times
All
with
right.
individuals that they may feel that they need X amount, where it may be beyond that 20-25 that, we feel is necessary. They may feel that they need 30 or 35. So a lot of it is just an individual basis, and obviously things that, what do the team needs? What time of year is it? Is it spring training? Is it we're about to be in the playoffs? A lot of factors in that.
Awesome. Thank you very much, guys. Appreciate it. I'm going to kick it back over to Adam so we can get on to the next section.
Thank you.